Good evening, dear students. As you all know, from this batch onwards, 2024 batch onwards, you are going to have only one essay in your theory part, both paper 1 and paper 2. And that one essay will be case-based, okay, completely case-based. Previous years, you had 2 essays and one will be case-based and one may be a normal simple essay. But since from this year onwards, it's only one essay, definitely it's going to be a case-based scenario. And sometimes the diagnosis will be given. Being a first year student, you will be able to make out the diagnosis very simple. It will be very simple and very easily you can make out the diagnosis. But sometimes it will be little tricky. But don't worry, if you understand the concepts, mostly it will be asked only from the common scenarios, common presentations. Okay, so this is just a primer of the case-based essay question and its discussion related to cardiovascular system. Okay, so whatever essay that you were preparing during the normal times, that is as a simple essay, now it's going to be a little deviated or little tricky. We will see how it goes on. Okay, so you would have read about coronary circulation and how it acts and on the heart, and what abnormality is actually produced because of some disturbances in the coronary circulation. So the first essay what we are going to discuss today is about the coronary circulation. Let us see how we can decode the essay. So I hope you are all able to visualize this case scenario. Okay, let me read out the case scenario for you. A 60-year-old woman presents to the emergency department with shortness of breath, lightheadedness, and chest pain described as being an elephant sitting on her chest. Okay, she had attained menopause at her age of 45. Her father died of cardiac disease at his age of 65 years. ECG was taken immediately and she was found to have changes suggestive of myocardial infarction in leads V5, V6, lead 1 and AVL. Okay. After baseline stabilization, she was proceeded for appropriate treatment. Okay, so this is the case scenario that is given. Now, look at the questions. Okay, there are 4 questions given here. Justify the diagnosis with a given clinical presentation. That is the first question, which carries 2 marks. Second question is, what are the ECG changes suggestive of myocardial infarction? Which part of the myocardium has been affected in this patient? So this carries 2 marks. Okay, this is a little tricky part, right? Explain the features, special features of coronary circulation. So that is the physiological part. That is the core physiology part. Usually we prepare only this, the students prepare only answer for this question, coronary circulation, from the textbook, right? Okay, so that carries only 5 marks. And last question is, what is the first line treatment for MI? Okay, so in this question or in this case scenario, you see the case scenario, you can easily decode. It is myocardial infarction. In fact, the diagnosis has been given in the case scenario itself. Sometimes they will ask the diagnosis. They give the ECG finding or the clinical presentation and they will ask the diagnosis. But here in this question, the diagnosis is already given. Okay. But the thing is, from the given history, you have to justify for the diagnosis. Okay, so you have to give the clinical presentation. You have to justify why it is MI based on clinical presentation. The second part is actually only if you read ECG and MI, you will be able to decode. Now you should know what are the ECG changes suggestive of MI, and they have given certain leads, right? V5, V6, lead 1 and AVL. Now what is that suggesting? Which area is affected actually in the heart? And the third part is a direct core physiology question. Last one is an applied thing. What is a treatment? Okay, in the treatment, you need not go in depth. Just it's 1 mark. Students, please note the marks given for each question and you have to answer appropriately. Okay, so see, the last question carries only 1 mark. That means if you just outline or if you just give an overview of the treatment, that's it. Okay, consider this is the maximum mark containing question. the core physiology. Okay, so students, I just advise you, even if you are not decoding the case scenario, not coming to the diagnosis, don't worry at all. The maximum marks is only for the core physiology. Okay, so don't worry about it. Don't get panicked because it is a case scenario. I'm not able to make the diagnosis and my entire essay will be wrong. Okay, don't get panicked by that. We'll see how to decode question by question. Okay, so first question is justify the diagnosis with a given clinical presentation. Okay, let us go through the clinical presentation now. Now, what is the diagnosis part actually saying? Clinical presentation wise, look at the age. It is 60-year-old, right? Okay, what are the symptoms? Shortness of breath, lightheadedness, chest pain. Typically, this is the chest pain that is important. Okay, now how is this chest pain being described? It is like an elephant sitting on her chest. Okay, so that means some severe pressure is acting on the chest. That is the clinching point of diagnosis. Apart from that, what are the other supporting features? Attained menopause. Okay, so that is one feature, because we will see why it is important. And father died of cardiac disease. That means probably it must be a coronary artery disease. Okay, so with this, we'll just try to answer for the first question. So what is the answer for the first question? Justification of your diagnosis. Okay, justification. So what is the clinical presentation? What is the age? It is 65 or 68 years. And she's a female. Okay, why it is important? Why it is important, students? Any guess? Let us have a rough work here. Okay, so why it is important? Why female is important? Because it has also been mentioned that she has attained menopause. Okay, menopause is also attained by her. So until menopause, during the reproductive years, the female is protected by her important hormone, estrogen. It is a cardioprotective hormone. So here menopause has been attained by the female, and 68 years. Age factor is also there, and lack of estrogen is also there. Okay, lack of estrogen. That is also important. So that is one clinching point. Okay, then main point is the pain. The pain here is somewhat called as compressive, compression, or pressure. Okay, it's a pressure pain. It's something like a heavy object sitting behind the chest. What are the other variants of the chest pain in MI? It can be crushing. Okay, it can be squeezing. Okay, it is mostly retrosternal. They'll keep their hand here. Okay, so it is retrosternal. Okay, and it may be radiating. The pain will be radiating in nature. Most commonly, the pain from the MI, they radiate to the left arm. Okay, so that is radiating in nature. The variance of the pain is the pain may be felt below the chin, or the pain may be felt in the epigastric region. These are all the variants. Okay, but these are the classical presentation of the chest pain in MI. Okay, then in our case scenario also, this woman is having the classical presentation. Then what is the next feature? Family history also positive. Father died of coronary event. So family history positive. So these are the features from the clinical presentation that gives you the justification for the diagnosis of myocardial infarction. And apart from that, she has been taken, ECG has been taken for her, and ECG findings, that comes to the next question. ECG findings also has been given suggestive of MI. Okay, so ECG finding is suggestive of MI. Now, why it is suggestive of MI? Now we'll have to know what are the ECG findings that is present in MI. Now, what are the ECG changes? The two cardinal changes in ECG when a person is having MI is ST segment elevation, and T wave inversion. Okay, these are the cardinal points of ECG. One is ST segment elevation, the other one is T wave inversion. Okay, let us see the normal ECG. It is P wave, QRS, and T wave. P, QRS, and T wave. Okay, this point is called as J point, right? This point is called as, this is J point is actually the junction between the S wave and the isoelectric line. So this is ST segment, this point, the beginning of, end of S wave and the beginning of the T wave. This isoelectric line is there, right? So that is the ST segment. In MI, how it will be? Okay, so I'll draw it in MI. It will be like this. The P wave will be normal, and QRS, J point will be elevated from the isoelectric line. Suppose this is the baseline. So J point is altered. ST segment will be like this, and T wave will be like this. So this is called as ST segment elevation, right? So this is how the ECG will be there. Now, the other point in this case scenario is the ECG changes are seen in lead V5, V6, then lead 1 and bipolar leads, lead 1 and AVL. So this ST segment and the T wave inversion are seen in only these leads, V5, V6, V1 and AVL. Now you have to know what are the areas that is represented by these leads, V5, V6, lead 1 and AVL. In general, let us see the position of the heart, okay? And related to the ECG electrodes. Lead 1 actually represents lateral part of or lateral wall of the ventricle, lateral wall of left ventricle, right? AVL, again, lateral wall of left ventricle. Lead 2 and lead 3, actually, they represent inferior wall of left ventricle, right? AVF also represents inferior wall of left ventricle. V1, among the chest leads, V1 and V2 represents right ventricle, okay? V3 represents septum. V3 represents septum. V4 represents anterior wall of left ventricle. And V5 and V6 again represents lateral wall of left ventricle, okay? So this is how the various leads represent the various parts of the myocardium. Now look at this from our question. V5, V6, lead 1, AVL. V5, V6, it is actually the lateral wall of left ventricle, okay? Then lead 1, again, lateral wall of left ventricle. AVL, again, lateral wall of left ventricle. So which area is affected? It is actually, the infarcted area will be lateral wall of left ventricle, or in short we can say the left ventricle is the one which is affected. Myocardial infarction is seen in the left ventricle, okay? So students, for this part of question, if you answer the ECG's changes suggestive of MI, in general it is ST segment elevation and T wave inversion, you will get 1 marks, right? And if you can mention, because it is specifically asked which area is affected from the given ECG findings, if you write left ventricle, that itself will give you 1 marks, okay? Because if you are very specific, if you give lateral wall of left ventricle, it's fine, well and good. But it's enough if you write left ventricle, then it's very good, okay? So this is how you can answer for the first 2 part of the question. What is the second question, which is the core physiology part? What is the second question? It is actually the special features. Sometimes they were also called as peculiar features because it is somewhat peculiar to the coronary circulation alone. So what is the peculiar features of coronary circulation? Okay, at least there are some 8 points for this coronary circulation special features. Okay, at least 6 you have to write. Let us try to complete everything. Now, for any regional circulation, you should start with schema of that particular circulation. How the artery comes to that particular organ, what are the changes or what are the special features in the capillary level, and then how the venous blood empties or goes away from that particular organ. This is a schema, okay? Like that, for coronary circulation also, there is one schema. The coronary arteries, there are two coronary arteries, right coronary artery and the left coronary artery. They arise from the root of aorta. Okay, so they arise from the root of aorta. We have two coronary arteries, right and left coronary artery. Okay, fine. Sometimes one of the arteries will be dominant. In almost 50% of the individuals, right coronary artery will be dominant. In 20% of the individuals, left coronary artery is dominant. And in 30%, neither of the arteries is dominant. Okay, so we will see after this coronary artery has been emerged from the root of the aorta, you know, there is some valves or eddy currents will be there in the root of aorta, so that it does not get closed or it is not going back during the cardiac cycle, changes in the cardiac cycle. Okay, so from this coronary arteries, what comes after the arteries? Yes, arterioles. I can hear you. Arterioles. Okay, after they divide, they becomes arteriole. And from the arterioles, what is the next hierarchy? Capillaries will be formed, and the capillaries will supply the all the oxygen and the nutrients to the for necessary for the myocardial cells for its metabolism. And from there, the veins will be formed. Capillaries and veins will be formed. Veins will go and end in a special venous compartment called as coronary sinus, or sometimes anterior coronary veins or cardiac veins, anterior cardiac veins. Okay, sometimes all these vessels, they get drained into the chamber of the heart directly. Okay, so they get emptied into the chambers, especially right atrial cavity. They get emptied into the right atrial cavity. So this is what is a normal schema. Root of aorta, arteriole, capillaries, veins, and then they drain into the coronary sinus. That is a major draining vein of the coronary circulation. From there, they directly empty into the right atrium. Right. But there are some variations or some extra things also in this schema. From the arterioles, they form arteriosinusoidal vessels. Arteriosinusoidal vessels. Okay. And they directly empty into the heart chambers. Right. From the capillaries, they form a special vein called as Thebasian veins. Thebasian veins. And they also directly empty into the right atrium. Okay. Sometimes what happens? The arteries, they form arterioluminal vessels. Arterioluminal vessels. Okay. They also empty into the chambers directly. Okay. And what happens is, one of the special feature of this coronary circulation is they are capable of creating collateral vessels along with the arterioles of extra coronary vessels. Say, for example, this arteriole, they form collateral vessels with arterioles of extra coronary vessels. That means these vessels are not supplying the heart. Okay, they are called as extra coronary vessels. Coronary vessels. Okay, these arterioles of the coronary artery, they form collaterals with that of the arterioles of the extra coronary vessels. This can happen only when there is some sort of ischemia or lack of blood supply. Immediately, the heart has to find some alternative way of blood supply. So they go for some collateral arrangement with the extra cardiac veins or vessels. Okay, so this is the schema of the coronary circulation. So any regional circulation, if they ask you peculiar features, yeah, you start with the schema, right? This is called as first part, that is schema, right? So, okay, so what is the next important feature? The next important feature what we are going to discuss is blood supply. Again, make this as a template. After schema, it should also always be blood supply through that particular circulation. So, blood supply to the heart, you have to write certain numbers or numericals for this. Okay, so what is the blood supply? What is the percentage? 4 to 5% of cardiac output is going to the heart itself. Okay, 4 to 5%. Percentage you have to write. What is the quantity? 250 ml per minute is going to the heart, or 84 ml per 100 grams of tissues. Why these are important, I am mentioning here, because the total amount of the blood flow should also be known, but at the same time, what is the tissue appropriate blood supply? That there is something called as tissue appropriate blood supply. 400 grams, heart receives 84 ml, okay, which is somewhat lower when compared to the other important organs like liver and kidney and all those other organs, okay. So it is only 84 ml per 100 grams per minute, okay. That is one part, blood supply. And in the blood, what else is going? Oxygen is going. That is most important ingredient. So what is the oxygen consumption of the heart? Okay. What is the oxygen consumption of the heart? It is around 29 ml per minute. Okay. And the very important peculiarity of coronary circulation is this oxygen extraction ratio. Oxygen extraction ratio. What is the oxygen extraction ratio? How much of oxygen is taken by the myocardial cells and how much is left into the veins? Usually 19 ml of the oxygen is going in the artery and 14 ml will be returning back in the vein. So that means how much of oxygen is utilized by the tissue? It is only 5 ml. But here that 5 ml accounts for about some 25-26%. But here in the coronary tissues, that is your myocardial tissues, the oxygen extraction ratio is almost 70 to 80%, because the heart is working 24/7. Okay, the heart is working 24/7. So what happens is they need more oxygen. The oxygen requirement is very high, so they extract most of the oxygen from the arteries. Okay, so that is why this is very important point. 70 to 80% is the oxygen extraction ratio. Okay, now going on to the next important aspect, next important point. Coronary circulation is said to be phasic. That means heart receives phasic blood flow. Okay. See, in all other systemic tissues, say for example, in all other, kidney or liver, whatever it is, the blood flows to that particular organ continuously through, irrespective of the phase of the cardiac cycle, whether it is systole or diastole, the blood flows continuously. Okay, but in the heart, it is not like that. Maximum blood flow occurs during diastole part. Okay, whereas in systole, what happens during systole? It becomes very less, minimum, or sometimes in left ventricle, especially the endocardial, subendocardial portions, it is 0. Okay, so that happens in systole. So this kind of phasic influence is said to be phasic blood flow. This is very, very important. Now, what happens during systole? Systole, whenever the muscle contracts, even this happens in the skeletal muscle, when the skeletal muscle contracts, the blood vessels which are passing through the muscles, they get compressed. Okay. Similarly, during systole, what happens? The myocardium contracts. Okay. Myocardium contracts. So this totally compresses the blood vessels. Okay, fine. Okay, especially when it comes to the subendocardial blood vessels, they are getting most affected because the subendocardial portion, they receive very less blood supply. Capillary density is very less in that region. So when the blood vessels are compressed, blood will not go to the subendocardial portion. That is why the subendocardial portion is prone for myocardial infarction. This is the area that is prone for myocardial infarction. Okay, so let me explain it somewhat in detail because this is very important. Okay, this phasic blood flow is something very important that is expected by every examiner in your paper. Okay, so let us, before going into the detail, let us see some pressure and the pressure gradient that is happening during systole and diastole in 3 different compartments. One is aorta, the other one is left ventricle, the third one is the right ventricle. We'll see pressure. Okay, first we'll write pressure here and we'll write pressure gradient. Now, what is this pressure gradient between what and what? Pressure gradient between aorta and the 2 compartments. What are the 2 compartments? We'll see. Now we'll see first what is the pressure in the aorta. Aorta pressure during systole, it is 120, and during diastole, it is 80. Okay, this is nothing but your normal BP, right? Normal BP is 120/80. That is what is the aorta pressure. Now, what is the pressure in the left ventricle? Left ventricle, during its systole, the pressure is more than the pressure in the aorta. That's how it can send its blood or pump its blood to the aorta. It should be more than the aorta. So it should be 121, little bit extra than the aorta. And during diastole, the left ventricular pressure is 0, right? Right ventricle, the musculature is 1.5 times less than the left ventricular musculature. So the pressure required is somewhat lesser. So right ventricle, the maximum pressure, that is systolic pressure, is 25 and the diastolic pressure is 0. Okay. Now, we can compute the pressure gradient between the aorta and the left ventricle. What is the pressure gradient? 121. Sorry, 120 minus 121, it will be -1. Okay. And what is the pressure gradient? During diastole, 80 minus 0, it is 80. Right? In the right ventricle, what happens? The systole pressure gradient during systole, what is the pressure gradient? 120 minus 25, it is almost 95. Okay. And during diastole, what happens? What is the pressure gradient? Again, it is 80. Now you see the pressure difference between the aorta and the left ventricle is almost -1. That means no blood supply will happen to the left ventricle during systole. Okay. So if you can see the graph, from the graph, this graph you should be drawing. Okay. In the exam paper, they will be expected. So we can draw the y-axis completely and x-axis. We can mark the phase diastole. Sorry. Okay. So this is diastole. This is systole. And now once again, this is diastole. Okay. So what is in the x-axis? We are going to mark 3 columns here. In the top column, we are going to mark the aortic pressure. Minimum pressure 80, maximum pressure 120. That is enough. Okay. Aortic pressure. Millimeters of mercury. Right? Okay. And we can also mark a column separating or representing the systole and diastolic phases. Right. Okay. And in the middle column, we will mark, maybe we'll choose some other color. We will mark the coronary blood flow. Okay. Especially for the phasic blood flow for the left coronary artery and the right coronary artery. That is the supply that is going to the left ventricle and the right ventricle. The left coronary artery will mark from 0, 20, 40, 60, 80, maybe I think little cramped, we'll see 100. Okay. Then in the right coronary artery, the blood supply is somewhat lesser when compared to the, this is the left coronary artery. Right coronary artery, we'll mark some other color, maybe this. We'll start from again 0, 5, maybe 10 or 15. Okay, this is right coronary artery. Okay, so the pressure in the aorta, how we can mark here is, normally the pressure in the aorta, it is actually ranging from 120 to 80. So somewhere we'll start, because it's in the diastole, it comes to the minimum at the end of the diastole, say 180, 80. Okay, and during systole phase, the pressure in the aorta will also raise. So it goes to the peak of 120. And then when the left ventricle stops, or the systole becomes weaker at the end of the slow ejection phase, what we can do is, there is a drop in the pressure, and after this aortic valve closes, there will be a incisura here, that is the dicrotic notch, and again it goes down to back to 80. right? This is about the aortic pressure. Now, correspondingly, how the blood flow will be there in the left coronary artery. Left coronary artery, it is around 84, like maybe it starts from 70 or around 60 ml. Okay, so we'll start from here, and when it goes to the systole, it gets a dip to 0, because the pressure, you can see it is -1, right? So there is no pressure gradient, no blood flow will be coming to the left ventricle. So it takes a steep dip here to 0, and very flow during when the pressure in the aorta increases, there is a very small flow to the ventricle. That too, this flow will be going only to the epicardial region, not to the endocardial region. Okay, and after the systole is completed, during diastole, it gets its maximum blood supply and then gradually decreases. Whereas the right coronary artery, the status is somewhat different here. Okay, so here it is some 10 ml goes to the right coronary artery, because it requires only less blood supply when compared to the left coronary artery. So it goes to, it doesn't go to 0, it stays in between some 5 or something. Okay, and then it gets its maximum blood supply during the systole, because you can see during diastole it is only 80, whereas during systole the pressure gradient is 95. Okay, so this 95 is somewhat greater. Even during systole, the right ventricle gets maximum blood supply only during the systole, because the pressure gradient between the aorta and the right ventricle is 95 during systole, but in diastole it is only 80. So it is this advantage that the right ventricle is getting enough blood supply during the systole itself than when compared to the diastole. Okay, so this diagram picture, this phasic blood flow is very, very essential. You have to draw, right? So this is about the phasic blood flow. That is over. That is the third point we have completed. This is the maximum or most important point. Then we'll go to the next important point, that is auto-regulation. Auto-regulation, right? Okay. Now, 3 important organs have this beautiful feature of auto-regulation. One is heart, the other one is kidney, the third one is brain. Okay. So what is this auto-regulation? In spite of changes in the mean arterial pressure, maybe from 60 to 140, in this range, if the pressure increases, the blood flow also increases. If the pressure decreases, the blood flow, like that. It has some maintained a constant blood flow in spite of the changes in the mean arterial pressure. Okay. Now, how this coronary blood flow also is maintained? By means of 2 mechanisms of autoregulation. That is 2 mechanisms. The one mechanism is my metabolic mechanisms, metabolic theory, and myogenic theory. Okay, so these 2 mechanisms, this is the same mechanism which is applicable to the renal circulation as well as the cerebral circulation. The same mechanism through which the coronary blood flow also maintains the constant supply of the blood to the heart. Okay, but in spite of that, coronary circulation is closely related to metabolism, its own metabolism. Okay, so that is the next important peculiar features. In spite of having the autoregulatory mechanism, coronary circulation is closely monitored by its own metabolism, coronary metabolism. You know which is the chief source of energy for the heart? Any idea? Is it the glucose? For other tissues, the glucose is the chief source of the energy. For the heart, 75% of energy comes from fat. Very good. I can see the response from Karpusami. Okay, 75% is from the fats. Okay. Now, how this coronary metabolism determines the blood flow? Coronary blood flow is directly proportional to oxygen consumption. Okay. Coronary blood flow is directly proportional to the oxygen consumption. If the metabolism is increased, that means oxygen demand is also increased, right? So what happens as a result of metabolism? Which is the end product of the metabolism? Any metabolism? What are the metabolic waste products? CO2, yes, very good. Water, okay. Can H plus come? Potassium can be released. In heart especially, there is one substance called as adenosine. This is very important. Don't forget the substance. Adenosine. Sometimes lactate. Okay. Prostaglandins. All these are the substances that are released by the metabolism that is happening in the coronary tissues. Okay. Especially when there is some ischemia in case of myocardial infarction, something like that. This too much of lactate will be produced. Okay. This lactate is responsible for the massive pain. Okay. The heart pain or chest pain that is very massive in nature, that is all because of the lactate, and this pain is proportional to the lactate that is produced. That means which is proportional to the level of or the area of ischemia. Okay, extent of ischemia. So there are two things that is contributing to this metabolism and the related coronary blood flow alteration. The main thing is myocardial oxygen supply. Okay, and the ratio of this with myocardial oxygen demand. Okay, oxygen supply versus oxygen demand. Now, what is determining the oxygen demand? It is the metabolism, metabolic rate. Right? Okay. And if the metabolism is greater, what is produced? Adenosine. Okay. Adenosine is a vasodilator. Vasodilate. Right. Now, what are the two factors that determine the oxygen supply? One is how much of the oxygen present in the artery, that is arterial oxygen content, and how much of the blood is going to the or supplied to the heart, that is coronary blood flow. Right? So these are the two factors that determine the oxygen supply. Now, what happens when the metabolism is increased? When the metabolism is increased, lot of adenosine will be produced. This adenosine is a vasodilator. So what happens? This adenosine will dilate the coronary blood vessels, and this coronary blood flow will be increased and oxygen supply will be restored in par with the demand, right? So it is the blood flow can be increased only in correspondence with that of the myocardial metabolic rate or oxygen consumption rate. Okay, so that is the most important peculiar feature secondary to the basic blood flow, right? Okay, now what are the other features? One is the regulation of the coronary blood flow by other neural factors. What are the neural factors that is present? Neural factors. We'll go to the neural factors. What is the blood supply to the heart? Is it autonomic or something else? Sorry, nerve supply. How is the heart innervated? Autonomic. What are the two autonomic nerve supply branches? Vagus, very good. And yes, I'm able to see the response only from Karpusamy. Forgot. Okay, I will explain. So, on neural innervation, or the innervation is sympathetic and parasympathetic, right? Sympathetic and parasympathetic, as with any other systems, right? Okay. Sympathetic, we have got two receptors. One is alpha receptor, the other one is beta receptor. Okay, alpha receptor, when it is activated, it causes vasoconstriction. We are talking only about the coronary blood circulation, I mean coronary vessels, vasoconstriction. Okay, beta receptors, when it activated, causes opposite, that is vasodilation. Right? Okay, so what happens in sympathetic system stimulation? So it increases the heart rate. When sympathetic system is stimulated, heart rate increases, myocardial contractility increases. Okay, contractility increases, metabolism also increases. So all the heart functions are getting increased. That we know. BP increases, cardiac output, heart rate, everything increases. But what happens as a negative feedback mechanism, indirectly what it does, when the metabolism is increased, it results in more production of adenosine. Right? Now, what is adenosine? It's a vasodilator. So it causes vasodilatation. On the other hand, what happens when parasympathetic receptors are M2 receptors in the heart. Okay, they are M2 receptors. What happens to the parasympathetic? Parasympathetic does not have innervation on the coronary vessels, but they act on the myocardial cells. They decrease the heart rate, they depress the myocardium, just opposite to the sympathetic system. So they depress the myocardium, and in turn, when the myocardium is depressed, what happens? Oxygen consumption is also depressed. Okay, so there occurs indirect vasodilatation. Right? So these are the things, indirect vasoconstriction. Right. Okay. So these are the neural regulation of the coronary circulation and its related cardiac functions. Now, what are the other factors? What is the other factors? One thing, the point number G, okay, collateral development. These are the special features, collateral development. As we saw before, whenever there is an ischemia to one part of the heart, that artery is getting occluded by some atherosclerotic development. So immediately atherosclerosis and block of or occlusion of any vessel, immediately collateral formation will be there. Okay, collateral formation. See, all these points, I'm just writing the hints. Even if you write like this in a flow chart or just the salient points or the keywords, that's enough for an essay. Okay, you need not write in a paragraph way and write pages and pages. This point, this is enough. Okay, this collateral formation happens with the extracardiac vessels or within among the coronary vessels itself. The next point, H, okay, reactive hyperemia. This is one other point. What is this reactive hyperemia? Same way, when a coronary artery is occluded, okay, what happens? And you remove the occlusion. You first occlude the coronary, there is some occlusion of the coronary vessel and the occlusion has been removed, like how you remove the atherosclerosis by thrombolysis and all those things. Okay, you remove the occlusion, immediately there will be increase in coronary blood flow, and this increase in coronary blood flow is actually happening because of adenosine. Again, adenosine will be produced in a lot in those tissues, and they will go and dilate the blood vessels, and that causes a sudden increase in the blood flow once occlusion is removed. This is called as reactive hyperemia. Something like what we feel over the skin. If you block the circulation over the palm and if you remove the occlusion, immediately there will be some reddening of the palm, right? That means there is more blood flow to that infarcted or ischemic area. Okay, so these are all the salient features. Let us quickly sum up the headings alone of the salient features. First thing is special features of coronary circulation. The very first point is you have to write the schema of a particular circulation. Here, the coronary circulation, you have to draw this flow chart. If you are very good enough, you can draw the coronary circulation heart from the anatomy knowledge. Okay. Then the second point is blood supply to the heart. Okay, you have to remember these numbers, which is very important. Then the third very important point that you should never miss it is the phasic blood flow. And what is this phasic blood flow? If you can draw this graph and if you can mention the pressure reason behind this graph, very good, beautiful. Okay, then you have got the autoregulation as the next important special feature. And the next very important feature that you should never miss is how coronary circulation is coupled with that of the coronary metabolism. Okay, then the neural factors regulating the coronary circulation, then the collateral development and reactive hyperemia. Okay, if you have completed all these points, then it is beautiful. You will get at least you will get the complete 5 full marks. At least if you can write 6 or 5 points, it's more than enough. Okay, now the last part of the essay here is the first line treatment, right? First line treatment of MI. So why this MI is formed? There is some atherosclerosis, there is some thrombus has been formed and in the coronary blood vessels, and it has gone and blocked some of the vessels. Okay, say maybe one of the branches of the coronary vessels, like left coronary artery, circumflex artery, all these are the branches. Any one of the branches has been have been involved in this. So what you have to do is, immediately, usually what happens is they do angiogram, and after ECG, after they find that MI is the diagnosis, they subject the patient for angiogram. Okay, and they will find out where is the block exactly, and immediately they'll go for thrombolysis. The treatment, or the key word here, what you have to do right, is thrombolysis. That is a first line treatment. Okay, thrombolysis. Right, now this thrombolysis is actually 2 types. One is medical, using the drug called as tissue plasminogen activator. You would have read this in hemostasis chapter. TPA, tissue plasminogen activator, popularly called as ADRPLEXUS. The drug name is ADRPLEXUS, tissue plasminogen activator. This is the medical thrombolysis, right? Now, when you are this drug ADRPLEXUS is not sufficient to lyse all the thrombus that has been formed, then you have to go for surgical procedure, that is coronary angioplasty, percutaneous angioplasty, and then stent replacement, followed by stent replacement. This is the treatment. If you write just these names, it's enough. You need not go into the depth of the treatment procedures. Previously, instead of tissue plasminogen activator, they were using streptokinase enzyme. Okay, that was creating some allergic manifestations, and a lot of complications were happening. And that's why that is given away now. Now we use only tissue plasminogen activator, that is ADRPLEXUS, and followed by stent replacement. Nowadays, the patients are treated with angioplasty and stent replacement directly once MI is confirmed. So this completes the first essay. So with this part, we have completed one essay. Short note, coronary circulation can be asked as a short note, and 2 or 3 reason out questions also. Let me tell you the reason out questions. One reason out question is why the blood supply goes to the heart happens only during diastole. That means they are asking what is basic blood flow. That is one reason out question. What is the first line treatment of myocardial infarction, and why thrombolysis? Okay, and the chest pain, the nature of the chest pain can be a reason out question. Okay, so these reactive hyperemia can be a reason out question. Collateral formation can be a reason out question. So this particular one question has completed essay, short note, as well as some reason out questions. This, let me tell you some variants of these questions. Okay, so we have got questions like they have given the diagnosis and they have asked only for the justification. Instead, they'll give the ECG changes. ST segment elevation is seen in the ECG. They will ask, what is the diagnosis? So once you find that ST segment elevation is there, then it is definitely MI. Okay, the gold standard of MI diagnosis is still ECG changes, and definitely that is the clinching diagnostic point. You should write what, if they, instead of this question, justify the diagnosis, they may ask what is the diagnosis, and for that they will give the ECG findings in the scenario itself. Okay, that may be the one question. And special features, of course, that will be the core physiological part, most commonly asked, First line treatment can be asked. They'll ask, how will you determine the coronary blood flow? How will you quantify the blood flow? Okay, there are two concepts. One is fixed principle. Okay, fixed principle is the one based on the arteriovenous oxygen consumption and the amount of oxygen that is consumed by the heart, and the difference, arteriovenous oxygen consumption. That can be an add-on question among this. Okay, what is fixed principle? Or how will you determine the cardiac output, coronary blood flow? By other methods like echocardiography, Doppler echocardiography, scintigraphs are there. Okay, so those are the other add-on questions which can come for only 1 mark or 2 mark. Always remember, it is only this question that matters. Okay, all other things definitely you can answer, but even if you are not able to make out, don't worry about it. You will get maximum marks if you just know the core physiology part. But my aim is to make you get 10 out of 10. See, in questions like this, case-based, structured essay question, they will have to give the appropriate marks if you write the appropriate keywords. Okay, if it is 2 marks, you have written all the points, they should give 2 marks. If it is 5 marks, you have written 5 points at least, they should give 5 marks. Okay, so this is how you can fetch points. Okay, right. So we have another case scenario also to discuss. Let me confirm with the team. Surya, do we have time for this? Is it okay if I take a half an hour more? I would like to hear from the students also. Yes. Okay. Thank you. So next question is quite simple, and we will be running quickly because you must be very tired already, and this question is very quite easy also. Okay. Just quickly we'll discuss. Right. So this case scenario is about the 45-year-old business executive who came with the frequent headaches, unable to concentrate in his routine activities. He has been worrying about the business a lot lately. He is a chronic smoker with a smoking intensity of 20 pack years. He consumes alcohol every day and spends most of his time sedentarily. On examination of his vitals, his pulse rate was 98 and blood pressure was 170/100. BP 168, and 170/100, okay. His BP was 168/100 and 170/100 on 2 similar occasions, which have been recorded at 15 minutes interval after rest in sitting posture, right? So this was a case scenario given. What is the diagnosis, immediate diagnosis? Can you make out? Yes, very good. It's hypertension. Primary or secondary? It's quite simple. It is primary. Very good. Okay. So how did you, the diagnosis, here they have asked what is the immediate diagnosis. Immediate clinical diagnosis, what we could make out here is he is having hypertension. Okay. He is having primary hypertension. I will tell you what. Okay. Now we have to justify the presenting symptoms and clinical features. So let us take the answers. First question, justification. Right. So what is the justification that we are going to give here? We will decode first. 45-year-old executive, because the profession says more about the health. Frequent headaches, unable to concentrate, okay. Worrying, that means he is under stress, right? Most important risk factor is chronic smoker with a smoking intensity of 20 pack years. Now, what is this pack years? So let us just list out all the points here. Age 45, executive, right? Then symptom is frequent headaches. And what else? He's become stressed, right? He is becoming stressed. That is also one of the symptom. Because of his business, he is becoming stressed. Okay. Then what is the risk factor here? Risk factor is smoking, alcoholic, sedentary lifestyle. Okay. Strong risk factors for any non-communicable diseases are these three: smoking, alcohol, and sedentary. What are the non-communicable diseases we commonly encounter? Hypertension, diabetes, obesity, cancers. Okay, so these four you should never forget. Hypertension is the first thing. Here, the smoking, he has got 20 pack years. Okay, what do you mean by pack here? If a person is smoking one pack every day for 1 year, he's said to have one pack year. Okay, so he has been smoking 20 pack years, means he has been smoking one pack every day for almost 20 years. So that is said to be 20 pack years. Okay, and alcohol consumption is there daily, though they have not mentioned how much quantity of the alcohol, but still daily consumption of alcohol is he's called as an alcoholic. Okay, sedentary lifestyle, that is very, very important risk factor. Sitting for 6 hours in the without taking a break is equal to smoking 3 cigarettes per day. Okay, that is the latest smoking intensity. That much risky is having a sedentary lifestyle. So this is the justification. Before the justification, they have been it has been asked about the diagnosis, right? So clinical diagnosis is actually, what is that? Hypertension, preferably primary hypertension, because they didn't mention about any other associated symptoms. Okay, so it is primary hypertension, which quietly manifests with all these risk factors and the symptoms, right? Now, what is the second part of the question? Define blood pressure, classify the mechanisms regulating the blood pressure. Now, can you tell me the definition of the blood pressure? Definition, I want just the two key words. What are the two key words? What are the two key words? What is blood pressure? Definition, it is the lateral pressure. Yes. Exerted on the walls of vessels, arteries, by flowing blood. Okay. So the key word here is this, the lateral pressure. Okay. And when the definition is asked whether they have specifically mentioned about the normal value or not, you have to write the normal value. So normal value, systolic BP, it is ranging from 90 to 140. Diastolic BP ranging from 60 to 90. Okay, that range should be mentioned. And if they might ask specifically what is pulse pressure and what is mean arterial pressure. What is pulse pressure? Quickly. We have only half an hour's time. Can anyone tell me? Pulse pressure is diastolic BP minus systolic BP. Okay. What is mean arterial pressure? These are all the practicals for you, right? I hope you are all first year students. And by now, the practicals on blood pressure would have been made, right? So what is, excuse me. Yeah, thank you. Right? Mean arterial pressure is actually pulse pressure is, somebody answered, systolic BP minus diastolic BP is the pulse pressure. Mean arterial pressure is diastolic BP plus 1/3 of pulse pressure is mean arterial pressure. All these comes in the practicals. Okay, so all these things you have to mention if asked specifically. Otherwise, definition alone is important along with the normal value. So this is about the second part of the question. Now we'll go to the third part of the question. They have asked what they have asked. This is the core part, carries a 5 full marks, right? So what is the third part? Various. Oh, one more part is missing. We have missed. Classify the mechanisms of BP regulation, right? So along with the definition, they have also mentioned about the classification, right? Classification, how will you classify? We can classify BP regulatory mechanisms. I'm writing in short form because of want of time, right? So we can say short term, intermediate, and long term. Okay, all these short term, intermediate, long term is coined based on the duration of action. Okay. Okay. Excuse me. So we'll quickly finish. Short term, based on the duration of onset of action only, we are coining. Short term is what is asked in our question, but we have to classify it. So short term is, we have baroreceptor, chemoreceptor, CNS ischemic. These are the key short-term mechanisms. Intermediate term mechanisms, we have 3 mechanisms again. We have renin-angiotensin mechanism, number 1. Number 2, capillary fluid shift mechanism. And third point is stress relaxation mechanism. Right? So these 3 are the 3 intermediate mechanism. Long-term mechanism, we have got ECF, volume mechanism. Okay. Renin-angiotensin aldosterone mechanism. These are long-term mechanism because they take a long time to get onset. Okay, get the onset to act. ECF, body fluid mechanism, or renal body fluid mechanism. It's also called as renal body fluid mechanism. Okay, just write this classification: 3 mechanisms for your 2 mechanisms for long term and 3 mechanisms for short and intermediate mechanism. But what is asked is only about the baroreceptor mechanism. I mean, short term regulatory mechanisms. Short term regulatory mechanisms. So you will have to write the baroreceptor. What are the short term mechanisms? First mechanism is baroreceptor mechanism. I just tell you in short what is baroreceptor mechanism. First, what you have to write is location. Next, working range. Okay, where are the baroreceptors located? So they are located in the coronary, sinus, and aortic arch. You will have to draw diagram for this. Okay, now you will have to draw the diagram of arch of aorta like this. We'll take red color. Arch of aorta, brachiocephalic trunk, right subclavian artery, right common carotid artery. Then you have got left common carotid artery and left subclavian artery, right? Left subclavian artery, left common carotid artery. Now, when both the right and the left coronary artery, we can right? So common carotid artery bifurcates into external and internal carotid artery. Similarly, here, external and internal carotid artery. Coronary sinus is here. Okay. So we have got receptors here. Internal coronary artery bifurcation. Similarly, aortic arch, we have got receptors here. All these X are actually the coronary sinus, baroreceptors. Okay. So the afferent nerves coming from this aortic arch is the 9th cranial nerve, glossopharyngeal nerve. The afferent nerves coming from the aortic arch is actually the 10th cranial nerve, vagus nerve. Similarly, from here, glossopharyngeal nerve, they come and they go to a structure called as nucleus tractus solitus in the medulla. Okay, so the buffer nerves, the meaning of buffer nerves means they buffer the BP. Okay, that is 9th cranial nerve and the 10th cranial nerve are the buffer nerves. Okay, so this is about the location and the structure of the baroreceptors. Now, the working range here is this coronary baroreceptors, they work over a range of range between 60 to 180 millimeters. That means when the blood pressure, mean arterial blood pressure changes between 60 to 180, these baroreceptors will work good. Okay, I think my battery is getting low. It's not getting charged. Excuse me, students.